Honorary Chapter Chairman Dr. K. Rajgopal for today's program. Today, as usual, we have two case presentations by the postgraduates, and with our Sunil as the moderator. Sir, I'll hand over the mic to you, sir.
Yeah, thank you, Dr. Sarvesh Rajaras. Sunil, am I audible? Yes, thank you. At the outset, I would like to welcome each one of you for this ASI, KSI, PG Clinics. For the information of every one of you, second Thursday of every month, 8 to 9:30 is our postgraduate time. And we started in March. So first was from Dharwad, second was from Hubli, postgraduates. And today we have two postgraduates here. And they are Vivek, Hariharan, who is from Devaraj Academy of Higher Education and Research, Kolar. And Dr. Rajashekhar from Sri Madhusudan Sai Institute of Medical Science Research, Chikkaballapur. I heartily welcome first these two postgraduates to this program. Now, we have two examiners here, Professor Sapna Purushottam and Professor Sreekar Pai. Welcome you to this program. And
good evening, sir. Good evening.
Good evening. Good evening.
Thank you. Thank you.
Thank you. Sir. Yeah. So I also welcome all EC members, surgeons, national EC members, and all our invitees, HODs, and every one of you to this program. It's very important to realize that there are many platforms, but this is also one of the platforms for postgraduates, so that you know the art of presentation has become the most important thing now. Everyone knows that with the YouTube channels and other things, when it comes to the issues of management, you'll be able to get something done, or you have followed many channels, many teachers. But please practice the art of presentation. That is one of the purposes of this also. In addition, some expert talks also. So now we have divided this into three levels. Like I think most of you know that for postgraduate who is presenting first and second, up to the history becomes the first one. Then we request the examiners to ask questions. Then comes the clinical examination, and the diagnosis later forms the management. Dr. Sunil will take you for this, and he will also guide you. So I request every one of you to keep yourself muted. And if you have any doubts, please put it in the chat here, so that Dr. Sunil will take it and examiners can answer, or some opinions also can be given from others. So with this small introduction, I invite, I welcome each one of you for this program. And Dr. Sunil, please take over. Thank you.
Yes, sir. Good evening, ladies and gentlemen. I thank our chairman, secretary, and academic coordinators for having given me this opportunity to moderate this session, this wonderful session. So, as sir said, this is the third successful PG clinics for this year, since the new office bearers have taken over. We have here with us experienced teachers with excellent academic careers. Let me first welcome Dr. Sreekar Pai. He's a professor of surgery at his alma mater, which is MS Ramaiah Medical College, Bangalore. He has also done MRCS from University of Edinburgh. Liked by his colleagues and students alike, he holds the post of Honorary Secretary of SSB ASI, that's Bangalore City Chapter. He has published 2 books and has authored 2 chapters in different books. So I welcome you, sir. Dr. Sreekar Pai, welcome you to the
welcome. Thank you, sir.
Session.
It is my honor and a pleasure. Thank you.
Okay. Let me also warmly welcome Professor Sapna Purushottam. Dr. Sapna, are you there? Okay, she's joining us shortly. Who heads the Department of General Surgery at Madhusudan Sai Hospital, Medical College and Hospital in Chikkaballapura. Trained from Kempegowda Institute of Medical Sciences and BLD Medical College, Bijapur, she is committed to providing higher standards of patient care and also surgical education. And as sir has already announced, we have two enthusiastic young surgery trainees from Kolar Medical College, that is Dr. Vivek, and Dr. Rajashekhar from, again, Madhusudan Sai Medical College. I also welcome all the teachers, office bearers. I think there are some prominent, eminent teachers and senior faculty here. I won't be able to take all the names. I think Dr. Chandrasekhar is there, Dr. Abhilash, Dr. Vijay Kamath, and I'm just telling the names of people I can see here. If I miss someone, just forgive me. So, Dr. Prashant, Dr. Prakash Dave, who is the HOD of Kolar Medical College, he has joined all the way to support his student. And whom am I missing? All right. So and HOD of HIMS is here, Dr. Ravi. And well, forgive me if I have forgotten somebody and I'm not able to see all the names here. So without much ado, we will move on to the first case of the session. Over to Dr. Vivek Hariharan for his case. Vivek, over to you.
Yes, sir. Good evening to one and all present here. Thank you so much for this opportunity.
Dr. Sunil, I was able to see Dr. Sapna.
Yes, sir. I'll give her a call and check. She said just now she will join in.
Yeah,
Dr. Sapna has joined, sir.
Okay,
Dr. Sapna has
Oh, she's
I'm
there.
here, sir.
Okay.
Thank you.
I'm in the
Dr.
meeting,
Sapna.
sir.
Thank
Yes,
you,
sir,
madam.
yes.
Thank you. Welcome.
Thank you, sir.
Welcome.
Thank you so much. I'm sorry I was a little late.
No
Please
problem.
pardon
No
me for
problem.
that.
You've not
Yes.
missed anything. You missed
Yes,
your
thank you.
introduction, although I gave a good introduction.
Oh, thank you. Thank you so much. I'm sure you would have. Thank you so much.
Right.
Yeah.
Okay. So we are moving to the first case, everybody.
Sure, sir.
Dr.
Sure, sir.
Vivek.
Sir, am I audible? Is my PPT?
Yes, Vivek, you are audible.
Okay, sir.
So your PPT is not shared.
I've shared my PPT, sir.
I think so. It is just open in your Windows. You can just press share screen. Now it is loading, sir.
Yes.
Yes, you can just go for full screen mode, sir.
Yes, sir. 1 minute.
You go to the full screen. Okay. It's on the top there, no? Slideshow mode. Or start from beginning, that whatever slideshow is there, no? Up.
Bottom you have this
After
hourglass.
animations
Yeah.
and slides.
Yeah.
At the top, you can see the slideshow name, right? Sir?
Dr. Vivek.
visible now, sir?
Vivek.
No, sir,
Yes.
no, sir. Just go on the top, sir.
Slideshow.
A slideshow, yes, sir.
Play from start.
Yes, sir.
Double click. Yes.
Yes.
Done.
Okay, sir.
Vivek, you can start.
Yes, sir. Details of this patient. Mrs. X, 37-year-old female, hailing from Kolar, who's a homemaker by occupation, who was admitted on the 4th of November 2024 with the chief complaints of pain abdomen since 6 months. Patient was apparently normal 6 months ago when she developed pain abdomen, insidious in onset, continuous in nature, dull aching type of pain over the right upper abdomen, not associated with diurnal variation, with no aggravating or relieving factors, with no history of radiation or referral of pain, not related to consumption of food. There's no history of periodicity. There's no history of nausea or vomiting, no history of fever with chills, no history of yellowish discoloration of eyes or skin, itching, high colored urine, clay colored stools. No history of abdominal distension, altered bowel habits. No history of blood in stools, dark tarry stools, no history of anorexia, loss of weight, loss of appetite or early satiety. No history of dyspeptic symptoms, no history of previous blood transfusion, no history of childhood jaundice. Past history, patient is not a known case of diabetes, hypertension, epilepsy, asthma, tuberculosis or ischemic heart disease. She underwent LSCS done 10 years ago and 8 years ago. There's no history of, patient is not taking any medications for her present complaints, or there's no history of oral contraceptive pills. Personal history, diet is mixed, appetite is normal, Sleep is undisturbed. Bowel and bladder habits are regular. There's no history of alcohol consumption or smoking. Menstrual history, she attained menarche at 14 years. Her LMP was on 3rd of November, date as on 4th of November. She has regular cycles of 28 days in which her menses occurs for 5 days. She changes 2 pads per day. There are no clots. Obstetric history, she's a para 2 living 2 with LSCS done 10 years and 8 years ago. Family history is not contributory. Summarizing the history, a 37-year-old female with no comorbidities presented with complaints of right upper abdominal pains in 6 months with no significant past medical or surgical history with no other symptoms. I'll continue, sir.
So, yeah, Dr. Vivek.
Vivek, we will take a
run
break
through
here
the-
and
Yes.
ask the examiners to
Right.
speak to you. If
Yes.
other audience has any questions or anything, they can put it in the chat box, please. Over to examiners now to speak further.
So, yeah. So, Dr. Vivek, you
Yes.
had gone through with the history,
Yes, sir.
but you should make something out of the history. I mean, I do understand that you asked all the possible questions that are related to it, but it doesn't lead to anything. So you've got a right upper quadrant pain, isn't it? That's what I'm telling.
Yes, sir.
Right upper quadrant pain. So now, from the history, you should try and make out one, what it could be, two, what are the complications of it,
Yes, sir.
and what is the three is what is the etiology for it. Now, what do you think cause of pain is due to?
Sir, etiology, I feel it could be a neoplastic condition. It is not
First, you have to know what it is. Now, I mean,
anatomy, like
no, first you have to know what it is. Yeah, what is the anatomical diagnosis? Like, what could it be?
sir,
When she's come with pain.
right.
What is your probable diagnosis, Dr. Vivek?
Probable
Madam,
That is what
diagnosis.
sir is asking. Provisional diagnosis is after your examination. So after your history, you have to come up with a probable diagnosis. So, like, what is the anatomical landmark? Where will you focus? Anything that it is pointing towards? I'm sure that's
Madam,
what sir is also trying to ask you.
right hypochondriac pain, madam. The anatomical organs which are involved are liver, gallbladder, hepatic flexure, pylorus of the stomach, renal, suprarenal, and duodenum. As of history, only few things I can say is the patient is having a dull aching type of pain, which can suggest a solid organ enlargement. Chronicity.
Enlargement, okay. One is you told all the anatomical organs probable in that area.
Yes, ma'am.
Okay. Anything according to the symptoms, the positive findings, you can narrow it down?
Only positive finding is dull aching type of upper abdominal pain, madam.
No diurnal variation, no variation with
There is no history of periodicity. There is no history of previous analgesic intake. There is no history of relationship with food. So all of this, I'm thinking of a stomach or a pylorus or a duodenal pathology, madam.
None of them is there. There's no history.
None of
Pylorus or duodenum will have periodicity. Pylorus or duodenum will have periodicity. That is the idea. Or loss of periodicity. One of the two will be the thing. Here, what is it? It's just been there and been. What about, does it cause disturbance in the sleep?
No, sir, there is no
What is
sleep.
what is it that the patient really feels? I mean, there is something that you need to pause and think, because this is like a dull aching pain, 6 months with no positive, no negative, but the pain is there. So for 6 months, whether she's seeked any treatment or has this pain been there 1 year back, 2 years back, 3 years, no similar like that. Something it is like a blank history. You just got one pain and associated with it, there is nothing which is adding on to this one. So it can be GI,
Yes,
GU, hepatobiliary.
Yes, sir.
Isn't it?
Yes,
Of
sir.
what do you think
Any
it
history
is
of
most likely?
loss of appetite, loss of weight, is there?
No history of loss of appetite or loss of weight, madam.
Nothing indicative of it being any GI malignancy also.
No, at least at the history, there is nothing suggestive.
There is nothing suggestive of that. Okay. No history of jaundice also.
No, ma'am. Sir, I'm sorry, sir. I didn't get your question. Your voice broke, sir. If you don't mind, could you repeat?
No, nothing. I didn't ask anything.
Okay.
No, I was just thinking GI, GU, or hepatobiliary.
Yes, sir.
Which organ would you think most likely is involved?
At this point, I would think of hepatobiliary as the more common.
More likely.
More
So,
likely. Yes, sir.
more likely to. So, do you think any food is causing extra pain, or in hepatobiliary, what do you think it can be due to? Do you think it is liver or anything else?
I'm thinking more of liver, sir, because the gallbladder history of referral of pain is not there. There is no history of dyspeptic symptoms, which is typically associated with gallbladder pathology. So I'm thinking more
But
of.
there is no history of anywhere distinctly or indistinctly jaundice, or even in the past history, there is no history of jaundice at all.
Yes, sir.
Okay. It has, I mean, from the history, you're drawing blank. That is my understanding, because it just gives you a sort of anatomical location of the weight, but it is not giving you an anatomical diagnosis. One.
Sir.
Two, without a probable anatomical diagnosis, you can never get to know what is the etiology or the complications for the same, right?
Yeah.
There is
Yes.
nothing you are able to make out. Even head of pancreas, even duodenal C loop of duodenum, gallbladder, liver, kidney, nothing. It is not making any particular sense, isn't it?
Yes, sir.
Right. We had Nas madam asking regarding diurnal variation, which you have not, which you denied that the patient has. And also she has asked any childhood history of jaundice,
Jaundice.
which
No.
also is not no history.
Yes,
So
sir.
basically you are drawing a blank, isn't it?
Yes, sir.
So, okay. Any questions, sir? Further than this?
Yeah, I just want to ask Dr. Vivek
Yes,
a question to you. Why it is not a renal pathology? First question. According to me, she has a renal mass.
The
What
pain
is
is
your-
not
Yes.
radiating. First thing is the pain is not radiating. There's no history of symptoms like hematuria or.
So the second question, obviously at PG level comes is it a must?
No, sir. 10% of
So-
patients have 10% of patients have hematuria, sir.
So now you know majority is with me. Now tell me. So when will you not get backache if it's a renal enlargement?
You get backache, sir, but there's no history of.
No, what I'm trying to tell is when you will not get. So that's what is important. If it is more anteriorly growing, more anterior.
Okay, sir.
You know, there can be posterior bulge also. Sometimes it can grow anteriorly.
Okay.
Similarly, very important here, not to waste the time. You cannot forget because this is a 6 months history, no? 6
Yes.
months.
Yes, sir.
So obviously acute inflammatory, all that we rule out undoubtedly, but also why not you think of adrenals? They are very silent. Adrenal, not necessarily functioning, non-functioning.
Functioning tumor is not.
No, non-functioning. What I'm trying to tell is, so keep the options open.
Okay.
Agreed? That is what everybody is trying to tell you. Don't
Okay.
go biased to the exam because you know the diagnosis, you know the reports, maybe that's a liver enlargement or whatever it is. We do agree that jaundice, all that is you're ruled out, but still think of the anatomical areas. It is not just hepatobiliary is there in the right side, and being a general surgeons and this one, we also, the urology also is a part of yours. Knowledge also is equally important. Okay, right? Okay. That's all my comments, Dr. Sreekar. Thank you.
Yes, sir. Just one more
There's a
thing.
que-
In this 6 months, did the person experience fever at all?
No, sir. No, sir.
Fever? No,
No,
at
sir.
all.
No, sir.
What could be the causes of fever? First, what could be the causes of fever?
Dr. Sreekar Pai, your internet connection seems to be little, problematic.
Yeah,
Yes,
can't
Just
hear
check that.
clearly.
You can switch off the video if it happens frequently. Okay. Yes.
Yes, sir. Yes, sir. We'll do that.
Sir, can you? Sorry, sir.
What is the reason for fever if the patient has the inhibited fever? What could be the causes of fever in this particular condition? 6 months history, on and off fever.
Sir, hepatitis is one cause of fever, sir. Cholecystitis, cholangitis can cause.
Cholangitis, excellent. And also, sir was telling about renal mass, no? So stasis, urinary state stasis. Okay. So that also could be the reason the fever can develop. All right. Okay. Some other question was there. One more question someone was wanting to ask.
Madam wanted to know, Naz madam wanted to know, what is the, why did you ask the childhood jaundice in this case?
One is indicative of chronicity, and second is if there is any congenital conditions, sir, like primary biliary cirrhosis. That is one condition we had in mind, sir. To rule that out, we asked for childhood jaundice, sir.
Okay. Right.
Right. I think we
Examiner,
will go
sir,
on
can we
to.
proceed?
Yeah, we'll go on to the examination.
Examination. All right. Vivek?
Yes, sir.
Yeah. Proceed with the examination. Yeah.
General physical examination. Patient is moderately built and nourished, conscious, cooperative, and oriented to time, place, and person. Temperature is 98 degree Fahrenheit. Pulse rate is 86 beats per minute. Regular, good volume, measured in the right radial artery. Blood pressure is 130 by 80 millimeters of mercury. Respiratory rate is 18 breaths per minute. And her height was 160 centimeters. Weight was 65 kgs, amounting to a BMI of 25.40 kg per meter square. General physical examination. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Per abdomen examination. Patient is examined in a well-lit room after taking informed consent in the presence of a female chaperone. Patient is examined in supine position. Inspection. The shape is protuberant. Umbilicus is central and inverted. There were no dilated veins, sinuses, visible pulsations, or peristalsis. There was a healed LSCS scar present, phalansteal incision. All quadrants of abdomen move corresponding to respiration. There were no flank fullness, hernial orifices were normal, no left supraclavicular fullness was present. Palpation, no local rise of temperature or tenderness. A mass is palpable in the right hypochondrium, extending to right lumbar and epigastric region of size, so 1 minute, sir. Of size 10 into 15 centimeter, extending from the right subcostal margin at the mid-clavicular line to 10 centimeters above the anterior superior iliac spine, and laterally from the right mid-axillary line to 2 centimeters lateral to the midline on the left side. It has well-defined inferior border, left and right lateral margin, inferior left and right lateral margin. Superior extent of the swelling is not palpable. Inferior border is rounded. The swelling is firm in consistency with a smooth surface, which moves on respiration and falls forward on bending forward. It becomes less prominent on head raising test. It is not ballotable. The fingers cannot be insinuated between the mass and the right costal margin. There are no palpable pulsations. There is no mass in the renal angle. A 2 to 2 centimeter swelling over the umbilicus is present, which is soft in consistency, reducible with an expansile cough impulse present. There is no other organomegaly or palpable mass. For abdomen examination, there was no left supraclavicular lymph node, and there was no ascites or free fluid in the abdomen. Percussion. There was a dull note over the mass, which was continuous with the liver dullness. There was no band of resonance between liver dullness and mass. Liver span was measured as 23 centimeters. Rest of the abdomen is resonant. Auscultation, bowel sounds were heard, which were normal, and there was no bruit present over the swelling, over the mass. Provaginal examination showed uterus normal in size and anteverted. Bilateral fornishes were free and non-tender. Rectal examination revealed no fissures or external hemorrhoids. The sphincter tone was normal. Fecal staining of gloves were present, which was normal in color. There was no deposits or nodularity in the pouch of Douglas. There was no Blummer shelf, and there was no growth palpable on rectal examination. Spine was normal. There was no deformity or paraspinal tenderness. There was no signs of liver cell failure. From head to toe examination, revealed no signs of liver cell failure. Systemic examination, cardiovascular system was S1, S2 sounds are heard. There were no murmurs. Respiratory system had bilateral air entry, normal and equal air entry. Normal vesicular breath sounds are heard. There were no added sounds. CNS examination showed no focal neurological deficit. At the end of this, sir, should I proceed or we'll discuss examination, sir?
Okay, we'll discuss examination findings, isn't it? Dr. Sreekar Pai?
Can you just go back to your
First slide.
per abdominal examination for the findings of the mass?
Yes, the next one.
Sir, that is palpation, sir.
Yeah, palpation. So on inspection, did you make out the swelling?
Sir, I was not able to appreciate the swelling on
Not able to appreciate. Okay. So mass palpable in the right extending to right lumbar region and epigastric of size 10 by 15, isn't it?
Yes, sir.
From right subcostal margin. So you think that this is hepatomegaly. What made you think that it is hepatomegaly? What are the important points?
You're not able to insinuate something.
I'll tell, sir. One is it's in the right hypochondrium. It moves on respiration. It moves downward on respiration, and fingers cannot be insinuated between the mass and the coastal margin, and there is no band of resonance, sir, between the liver dullness and the mass.
Any other findings of the mass you have, Dr. Vivek? Like the surface, the edges, yeah. You mentioned that?
Yes, ma'am.
Surface is, what was the surface?
It was a smooth surface, sir.
And inferior border was rounded, you mentioned, isn't it?
Yes, sir.
Inferior border is rounded. It's not, what other types of border can occur?
You can have a sharp inferior border.
Sharp border. Why did you mention it is rounded? In what conditions do you get rounded?
Secondary is in the liver, sir.
Secondary is in the liver. Why it should get rounded? In
Is
what
secondaries
conditions?
in the liver it's nodular, or is the inferior border rounded?
Secondary is nodular. In hepatocellular carcinoma, it is rounded, sir.
No, Dr. Vivek. The idea of rounded comes in mainly in cases
Cirrhosis,
of medical.
Cirrhosis or
Medical.
infiltrative disorders, sir.
Hepatomegaly due to hepatitis, due to medical reasons, mainly medical reasons. Whereas in secondaries of the liver, the anatomy of the liver is preserved. So it is always sharp margin. Okay. So surgical, generally, it will be a sharp margin. It won't be a rounded margin.
Okay, sir.
So sharp margin. So as you are examining the liver, it's very important to note the surface of the liver, whether it is nodular, whether it is smooth, all right, and the border, whether it is sharp or rounded.
Okay, sir.
Generally, in surgical findings, it will be sharp, all right.
Okay.
Second very important thing in examination, how do we begin our examination? Palpation, how do we generally examine on palpation? How does it begin with palpation?
We start with no local rise of temperature or tenderness, sir.
Tenderness. Did you examine for tenderness in the liver?
Yes, sir. There was no.
Not mentioned.
Yes, sir.
mentioned. Is it mentioned?
Yes, sir.
Doesn't- or no local rise of temperature or tenderness. We are not bothered much about local rise of temperature. We are bothered more about the tenderness. Okay.
Okay,
So
sir.
here, what are we looking at? Whether it is a tender or non-tender. So you are thinking it is non-tender, isn't it?
Non-tender. Yes, sir.
Non-tender, very important. Non-tender. The borders, what would you put it as, rounded or sharp?
What I appreciated, I felt was rounded, but
Rounded. You felt it is rounded, but the smooth surface, isn't it? Surface is
yes, sir.
smooth, non-tender, and it moves well with respiration, all these features, and it's an enlarged liver, isn't
Yes.
it?
Yes, sir.
What is the automatic organ that you should see for whether it is enlarged or not?
Stomach is one organ.
No, Vivek, not stomach. Which else? Which is a close associated with the liver?
Gallbladder, sir.
Gallbladder. Is it?
Yes.
Is it enlarged or not?
It was not palpable, sir. It's not enlarged.
So you should make an effort to mention that it is non-palpable gallbladder, isn't it?
Okay, sir.
And you are not feeling any fissures. What about the left lobe of the liver? Is it palpable or not?
It was a uniform swelling. It was a uniform mass arising from the liver, sir. It was extending till the epigastrium. So separately, the left lobe I could not palpate, sir.
Is it going beyond the midline or is it staying?
It is going beyond the midline, sir.
It is going beyond. So you feel that it is
It could
enlarged uniformly.
It could. Yes, sir. It
So
clinically.
the whole liver is enlarged. You are not having a focal area of liver enlargement.
No, sir.
You are having a whole liver that is enlarged without the gallbladder being enlarged, and there is no nodularity, nothing is there, isn't it?
Yes, sir. Because
And it is non-tender.
why the whole liver I'm telling is because of the extent, sir. It is extending till the crossing the midline. That is the reason. Epigastrium is involved, sir. That is why.
Epigastrium is involved, as well as it is. Is it going beyond the mid-axillary line, or is it stopping short of mid-axillary line?
Stopping at the mid-axillary line, sir.
Stopping short of mid-axillary line. Where did you measure the liver span?
Sir, at the mid-clavicular line from the level of the fifth intercostal, fifth rib till the lower border of the liver.
Generally, liver span is on the mid-axillary line, which is having the largest volume, not the mid-clavicular line. Okay. And where is it enlarged from above?
From the fifth rib, sir.
Fifth intercostal space. Okay. So it's a uniformly enlarged liver. I will tell it's a medically enlarged liver. The cause is medical. What are the medical causes of liver enlargement you can think of? You are telling it's rounded.
Yes, sir.
What could be there? The reason of medical causes of liver enlargement?
Hemochromatosis, glycogen storage disorders.
Okay.
It is non-tender, but if it was a tender swelling, then congestion,
congestive cardiac failure. How will you make out congestive cardiac failure? Yes or no? If it is, say, I will tell, so 37-year-old lady, she's probably having congestive cardiac failure with hepatomegaly. How will you make out?
Sir, first thing is the swelling is non-tender, sir. This patient will have elevated.
Another
JVP,
important thing.
Elevated JVP.
Elevated
JVP.
So did you mention it in your examination? Elevated JVP?
Sir.
Not mentioned. Okay, fine, no issues. And you told no signs of liver cell failure, isn't it?
Yes, sir.
So again, we are drawing a blank on our examination finding. Apart from hepatomegaly, there is no ascites, and I think there is one umbilical hernia. That's what you have made out, no?
Incidental findings, sir.
Yeah. I would like Sapna, madam, any other question you have, madam?
Yes, sir. You've covered most of it. Yeah. So in okay, I'll ask you a question. What are the liver cell failures that you to see whether he has chronic liver disease? What are the signs that you looked for?
Head to toe, ma'am. Alopecia,
Yeah, head to toe. Okay.
icterus, fetor hepaticus, and parotid swelling, and spider navy, caput medusae in males.
She didn't have any of these.
She didn't have any of these.
No cachexia, no.
Her BMI was
Okay.
25.4, ma'am.
25. Okay. So did you auscultate? Anything you found on the mass? Did you auscultate the mass by any chance?
I auscultated and there was no bruit that I could appreciate.
You could not see any, you could not hear any bruit also. Okay. Any features of any portal hypertension, etc. was there?
No, ma'am.
No for features of portal hypertension also. Like sir said, it's a complete blank. So it's negative in all ways, both history and examination wise.
So what do we do we put it as? Young lady. Yeah, what are your differential diagnosis? Young lady, I would like you to sort of summarize on your examination. What is your, overall summary, if you would like to put it? You already summarized the history, which is of a young lady, relatively young. What is her age?
37-year-old female.
37-year-old. So 37-year-old lady coming with history of abdominal pain on the right upper quadrant, isn't it? That's all. And on examination, what do you have? Can you summarize that?
Only hepatoma.
Yes, sir.
Only uniform hepatomegaly, isn't it?
Yes, sir.
Uniform non-tender hepatomegaly with no gallbladder enlargement and no evidence of liver cell failure, is what you are telling, na? Okay. So how would you put your differential diagnosis?
First, provisional diagnosis. Why do you say that? What are the points supporting it? You can mention. Dr. Vivek?
Yes, ma'am. I'm going to. Hepatic adenoma is my first differential diagnosis. It has a male and equal male and female preponderance, and it is a space occupying lesion which can grow to large sizes, and this patient does not have any features of malignancy, so it is a benign course. It has a potential for malignant transformation over a long period, and that's all. It's a firm, swelling, smooth surface. Features are of one differential is hepatic adenoma.
So you are looking at more benign condition, isn't it? That's what you're looking.
It's a relatively young female. Therefore, I'm thinking of benign conditions.
And how long has she had the pain for?
She's had the pain for 6 months, ma'am.
6 months. So that's also shows chronicity, right?
Yes, ma'am.
Yes.
There's no history of fever to indicate anything inflammatory. So hepatic adenoma is one.
So sir has certain pointers, Rajagopal Shanai sir, towards palpation. So we would like to ask sir to
Vivek,
this valuable.
Vivek, one point is that why did you mention last that go back next slide? Why this no sense of liver cell failure came now? So that should not happen.
Beginning.
That's why we say general physical examination, head to toe is at least you start with the pallor, jaundice and all, no? So in retrospect, you can always check if your case, if you seriously think there is a liver pathology, etc. Okay, that's number one. Number two, go back. So I'll not take much time. Go back. Go back. Yeah. No, back. See, when you describe the extent of the mass diameters, slide number 17. Yes. Hold on to this. So there are one or two things when the mass moves with the respiration. Less prominent on head raising is not required because it is intraperitoneal and it automatically becomes intra-abdominal. Okay, number one. Number two, mass, such a mass, which a huge size, do you expect it to fall forward on bending? I don't know, because first of all, you are telling it's a liver.
Yes, sir.
I don't think there is any doubt about that. Even if all of us are sitting without examination, it looks like liver only. Don't expect the liver for such a massive size to fall forward, because you need some space, and it's not required.
Oh.
This one bending forward, that is
Okay.
one thing. Just 2 comments. And when you describe the diameter, you better mention vertically how much and horizontally how much.
Today, how much?
For
Yes.
example, if you say no, large kidney is there, large kidney, polycystic, or whatever renal cell. So they all vertically more than always horizontal. You understand? On the
Yes.
other hand, mesenteric
Yes, sir.
cyst. There are some things related to diameter. For me, it looks like a right-sided, large space-occupying mass. Left lobe,
Yes, sir.
probably it is not. It doesn't look like arising from the entire both lobes. Left lobe is relatively small only. See, if you look
Okay.
at carefully, when the right lobe enlarges, it gives a picture as if both lobes are enlarged. Sreekar, these are my comments.
Yes, sir.
Thank you.
Yes, sir. Thank you,
Thank
sir.
you, sir.
Thank you.
Thank you, sir. Thank you so much.
Second differential diagnosis is hemangioma. It is a benign lesion. It is most commonly occurring benign lesion of ma'am. It's a benign lesion. It's the most commonly occurring benign lesion of the liver, and it has a female preponderance. And it has been documented to grow to a large size, a giant hemangioma. Points against hemangioma is one, there is no bruit, and second, there are no symptoms of like bleeding diathesis. There are no symptoms if it has attained that size. There's no history of bleeding diathesis. So that is the point against hemangioma.
Generally, there won't be any bleeding diathesis,
Yes.
and hemangioma won't cause any bruit. Okay, so it is
Okay, sir.
unlikely to cause any bruit. All right.
In fact, your
So
hepatoma causes more bruit than your hemangioma.
hepatoma, yeah, hepatoma is the one which, because it is not this one. So
Okay.
I mean, you cannot give a differential diagnosis of benign and malignant. Okay,
Malignant,
try
yes.
and avoid these kind of contradictory statements, which will land you up in trouble. Why would you tell it as hepatocellular carcinoma? Isn't it? So there is no history of nothing which is malignant, and the patient is well built, nourished, 25, 26 BMI, not lost weight, not lost anything. So we are trying to gain from the history whether it's benign or malignant. So you should not err so much on to.
Okay, sir.
Yeah, okay. So
That
it
was
would be probably benign.
Okay, sir.
Any other webs around this one which can cause? What is that?
Sir?
Along the hepatic veins, webbing.
Budd-Chiari syndrome, sir.
Budd-Chiari syndrome. Can it be Budd-Chiari syndrome?
Again, it will be a tender hepatomegaly, sir.
Tender hepatomegaly. Anyway, I think, generally, this is like a blank conclusion for us, but differential would be more of a benign. So
Benign.
as you put it as, adenoma, hemangioma, or hydatid cyst of the liver. The hepatocellular carcinoma is a wolf among the sheep. Okay. So I would rather avoid such a cross differential diagnosis. Okay. So for all practical purposes, at least you are sure one thing anatomically that it is liver.
Yes, sir.
And two very important thing is its cousin gallbladder is not enlarged. Say now gallbladder is enlarged. What are the thought processes that can occur to you?
Gallbladder carcinoma with secondaries in the liver is one.
Gallbladder carcinoma with secondaries in the liver.
Anything else?
Anything else?
Yeah. If it is obstructing, then it is causing like empyema or mucocele of the gallbladder.
Mucocele of the gallbladder. It will be at least somewhere tenderness would be there, somewhere cholangitis, somewhere history of acute cholecystitis will be there.
Yes, sir.
Here it is not at all. I mean, it's a dull aching pain.
Yes, sir.
There is no this one. All right. So, what is the law which guides us in cases of obstructive jaundice? Which law guides us?
Courvoisier's law, sir.
So, could
No, what
you
does it state?
In a case of obstructive,
Yeah.
in a case of obstructive jaundice with a palpable gallbladder, the obstruction is extraluminal.
No, there is a definition.
Okay.
You have to put it defined.
In a case of obstructive jaundice with the palpable gallbladder, if the gallbladder is palpable, then it is not interluminal. It is
Seldom due to
Seldom due to
seldom due to intraluminal obstruction. It's due to gallstones.
seldom due to stones.
Stones.
Okay.
Okay.
So
Hmm.
it's an important law which guides us to management of the condition. So what are the exceptions for that?
Empyema of the gallbladder and
Mucocele.
mucocele of the gallbladder.
Double impaction.
Double impaction.
Right?
Yes, sir.
Okay.
Right, sir.
So,
Dr. Sunil, so that by another 5 minutes we can wind up.
Yes, sir.
Any
Yes, sir.
imaging.
what investigation?
So-
What
Imaging
investigation?
and this one, yeah.
Directly
You can continue, Dr. Vivek. Huh?
Ultrasound of abdomen and pelvis showed a heterogeneously hyperechoic lesion in the right lobe, which is suggestive of hepatocellular carcinoma, along with a right paraumbilical defect of 1.2 centimeters. After the ultrasound, we proceeded to get a CECT of the abdomen and pelvis in a triphasic phase.
Dr. Vivek, anything in the blood investigations that you've mentioned?
Nothing significant.
Liver,
AFP was
LFT, you know,
normal. LFT was normal. AFP was normal. Coagulation profile was normal.
okay.
Everything was normal.
Okay.
CECT, abdomen and pelvis. The image on your left is the arterial phase, portovenous phase, and the delayed phase. In that,
The triple phase CT.
it shows a peripheral. It shows early arterial enhancement, the peripheral limb enhancement, with washout in the delayed phase, in the portal phase and the delayed phase.
So that's typical. That's characteristic.
Yes, ma'am.
Okay.
This is a coronal section of the same, showing the extent of the tumor.
Just a second.
So settled, huh? Do you need a FNAC for confirmation, Dr. Hariharan?
Sir, actually, based on the AASLD criteria, if a lesion is more than 2 centimeters, and CT, one imaging modality CT is confirmatory, sir, with the alpha fetoprotein level. We don't need an AFP, sir. We do not need an FNAC, sir.
We do not need an FNAC. Is a statement, isn't it?
Yes,
An
sir.
important statement. Tumor markers without a FNAC
Yes,
and
sir.
a triple phase CT is confirmatory of a hepatocellular carcinoma.
Yes, sir.
So, what would be your briefly management of this this lady?
This patient was a hepatocellular carcinoma in a setting of non-cirrhotic liver, and she was therefore child POOG A category, sir. So the treatment was curative and the option was surgery. She underwent right-sided extended hepatectomy with segment 4B preservation, sir. Preoperatively, her future liver remnant was calculated to be 30%, and therefore we went ahead with a right-sided extended hepatectomy, sir.
Quite large for a hepatectomy, but I think anyway, the ideal things will be less than the hepatocellular carcinoma curative intent will be in which size? What size of the tumor?
Less than 2
Usually
centimeters is
4 centimeter, 4 centimeter, 2
centimeters.
centimeter lesions of 3 up to 3 in
Multiple.
one segment. Yeah, one segment area. So you do not, I mean, this is quite large. Definitely, luckily, it could be operatable. But otherwise, what is the other possible solution you can have? What can you do? What can you do before pre-operative? Can you do something to reduce the size?
We can give portal venous embolization can be done, sir, to reduce the size of the tumor and cause hypertrophy of the normal function.
Coil, yeah, and intra chemotherapy or coils can be instilled to reduce the size of the
Tumor.
lesion.
Yes.
Yeah.
Yes, sir.
Before venturing out. Okay.
Okay.
Right. Thank you. Any other things, sir? Rajagopal sir, Sapna madam, Sunil Joshi sir.
Any operative
Anything to
pictures you have just to show us?
I do, sir.
No, nothing. I just thought one. Yeah, I think that's what you should mention. That probably metastatic workup. You understand, no, Vivek?
Yes, sir.
Yeah. Once you have done with the investigation and you have a strong suspicion of this hepatocellular carcinoma, that's what you said. So immediately the word should come as a metastatic workup. You understand, no? So
Okay,
that's how it starts with the staging and follow. For me, the whole thing is looking like a big exophytic mass, exophytic.
Mass.
If you see that, see the CT picture, that one picture wherever he has shown, it's very huge one, correct? See that?
Yes.
See this?
Yeah.
This is the
Hanging. It's almost like, that we get sometimes a large hemangioma. No wonder he said that it is falling forward. Actually, if you see this picture, there was some space for it to fall forward, I suppose. See, it's finding, he said that because it is so much hanging down like this, Hey, okay, that's all. Dr. Purushottam, you are there. Just one or two comments, sir. You are there?
Fine, sir. But the boy said portal vein embolization. It is not the portal vein, it's a hepatic artery embolization.
Hepatic artery.
Whenever we have tumors, feeding vessel is a hepatic artery, not the portal vein.
okay, sir.
Trans-arterial
hepatic artery.
It's called TACE, trans-arterial chemoembolization. That's what it is called.
And hanging variety of SCC is a known clinical entity. Hanging type. It is a known entity. And when the question was asked which are curable intent, if SCC, in spite of going big, if it is a hanging variety, it is one of the curable resectable tumors of the liver. Hanging variety. Yes, sir.
Thank you,
sir.
Thank
you, sir.
Thank you, Vivek. You have done a good job. Good presentation.
Great.
Minor correction.
Yeah, excellent.
Okay. Thank you.
Excellent.
Thank you.
Thank you, Dr. Vivek.
Very good
And-
presentation, Dr. Vivek.
Okay,
Continue this one.
Thank you, sir.
Okay.
Thank you.
So we will present. We'll continue with the next presentation.
Okay.
Yeah.
Dr. Rajashekhar from Sri Madhusudan Sai Hospital, Chikkaballapur, to present his case, please.
Vivek, unshare.
Yes, sir. Good afternoon, sir, everyone. Today I am presenting a obstructive jaundice. Can I start, sir?
Yeah, slideshow. Oh, yeah. Make it
Switch on
slideshow.
the slideshow, Rajashekhar. Yeah. Yes.
Can I start?
Yes, please. Yes, please.
A 64 years old male who is former by occupation came from Chikkaballapur. He was examined on 22nd 4th 2025. He came with chief complaints of yellowish discoloration of eyes since 6 months. History of present illness. Patient was apparently normal 6 months back. Later, he developed a yellowish discoloration of eyes, which was insidious in onset and gradually progressive in nature. It was initially lemon yellow in color and later progressed to a dark yellow in color. Over the past 1 month, he also developed a yellowish discoloration of palms and soles. He did not have any waxing and waning of jaundice. Patient complaints of pruritus all over the body since 3 months, which was insidious in onset and progressive in nature, which was interrupted the daily regular activities. Patients also complaints of on and off pain abdomen localized to epigastric region and right hypochondrium since 2 months, which was dull aching type and mild to moderate in intensity and non-radiating type of pain, no aggravating and relieving factors. History of on and off fever for past 2 months, which was low grade, not associated with chills or rigors. History of high colored urine since 1 month. History of clay colored stools since 1 month. History of significant unintentional weight loss around 26 kgs in 6 months with decreased appetite. History of blood loss in stools. No history of blood loss in stools. No history of evening rise of temperature or chronic cough. No history of abdominal distension. No history of breathlessness, palpitation, and back pain. No history of malaise, arthritis, skin rashes. He has no history of chronic intake of medications like anti-epileptics, antibiotics, ATD, and NSAIDs. No history of gum bleeding, epistaxis, visual disturbances, or bony pain and gait disturbances. Past history: patient is a known diabetic and regular oral medication since 9 years. Not a known hypertensive, TB, asthma, or epilepsy. He had no history of previous surgeries. He had no history of similar complaints in the past. Personal history: he had a mixed diet with good decreased appetite. Bowel and bladder habits are altered. Sleep is disturbed. Known smoker, which was 40 packs per year, 40 packs years. Not a known alcoholic. Family history: no other family members are suffering with the same complaints. Medical history: Ayurvedic medications are taken for the similar complaints. Summary: 64 years old gentleman, known diabetic, presented with complaints of yellowish discoloration of eyes, itching all over the body, dull aching type of pain abdomen associated with passage of high colored urine, clay colored stools with on and off fever, significant weight loss with decreased appetite, suggestive of obstructive jaundice secondary to most probably malignant etiology.
Sir, at the end of the history, examine this, please.
This gentleman, can you just tell us what is his chief complaint?
Yellowish discoloration of eyes, sir.
So can you modify your chief complaint? Can you modify?
Jaundice.
No, this is correct. Yellowish discoloration of eyes in 6 months, which is progressive or has been static?
It's progressing, sir. Gradually progressing.
Yeah. One. Second important history, chief complaint will be?
Pruritus all over the bodies since 3 months.
So that is associated with the jaundice. Very important thing is loss of weight and appetite over a period of
6 months.
6 months. So you have to make it as a chief complaint. All right. So it is important that you give an idea to the examiner what you are dealing with. So you've got 6 months progressive jaundice associated with loss of weight and appetite over a period of 6 months, which is significant in nature. So although it has come as you have taken the history, it becomes a chief complaint. Okay. Chief complaint. All right. So that is very important. All right. And can you tell which, how much has it extended, the jaundice? Does he experience pruritus all over the body or is he experiencing it any particular area? How is it distributed all over the body or specifically anywhere?
Pruritus is distributed all over the body, sir.
All over the body, isn't it? All over the body. And he doesn't feel any mass in the abdomen, nothing. He's just come with jaundice, isn't it?
Yes, sir.
Any history of hepatitis in the past? Any history of blood?
No history of hepatitis.
No history of any history of surgeries or anything which has contributed to the jaundice? Nothing.
No, sir. No history of previous cholecystectomy, sir.
Okay.
Any history of melena or anything?
No, madam. No history of melena or blood in stools.
Blood in stool. Okay.
So it is not medical jaundice, it's surgical jaundice. This is what you are trying to make out from the history, isn't it?
Yes, sir.
Surgical jaundice. Okay. Could you identify the cause, what it could be, and what is the etiology for it? Can
It's
you, by the
progressive
history,
jaundice, sir. Gradually progressive
obstructive
jaundice.
jaundice due to what?
Most probably due to carcinoma head of the pancreas, sir. There is no vaccine and waning of jaundice, sir.
No, what? How would you make out in a history? It is from the pancreas.
Any pain the patient experienced?
Yes, madam. His upper abdominal pain is there, and dull aching type of on and off pain is there, and progressive jaundice is there, and there is no waxing and waning. And most
So
probably,
what would be if it is from the pancreas? What kind of pain will the patient experience?
he had radiating type of pain also will be there, sir. Radiating to back.
Back one. Okay. Second, what are the other causes of jaundice? What other causes can lead to obstructive jaundice?
Yes, sir. Malignant causes periampullary carcinomas are there, and
Why are you
most
thinking only malignancy, Rajashekhar? Anything else?
his age is elderly age, madam, and
Okay.
and the loss of weight and appetite is there.
Significant.
Very good. Okay.
Mm.
And maybe associated with TB also will be there, madam. TB, lymphadenitis, and the hepatitis will cause obstructive jaundice.
Not TB adenitis. Don't go for TB. It will be malignant. Malignant lymph nodes at the porta hepatis. Where does it come from? Which organ does it originate from? These lymph
Yes,
nodes.
sir. Carcinoma stomach, it will cause.
So, did you take history for ruling
Yes.
out CA
He
stomach?
doesn't
What
have
will be
any.
the history?
He doesn't have any melena history, sir, and any gastric
JIT?
ulcer.
Okay. Any other history that you can think of? History of periodicity of the pain in the past, isn't it?
Yes,
so, if it is associated with periodicity of
Jaundice.
pain, and now it is not there. Okay.
Yes.
So he has got no past history except for 6 months, na?
Yes, sir.
And no history suggestive of hepatitis B
Yes, sir.
exposure.
No blood transfusions, no arthralgia, myalgia.
So these are the history that could lead to the malignancy. Another thing is any other cause. So pancreas, stomach, right? These
Yes,
are the
sir.
major causes for malignancy. The other possibilities, what are the other possibilities that you can think of?
Sir, distal cholangiocarcinoma, sir.
Distal cholangiocarcinoma, CA gallbladder extending onto the CBD. So these are the, primarily hepatocellular carcinoma. Can it cause so much of jaundice?
No, sir.
No, unlikely, isn't it? Unlikely.
Yes,
Okay. So you're looking at obstructive jaundice. Anything, sir? Madam, anything you want to add? Anything?
I think Shinoy sir had some questions. Sir, you can ask, sir.
Rajashekhar, no? Rajashekhar.
Yes, sir.
You are there? Yes.
Yes, sir.
What is the difference between intermittent fever and intermittent jaundice and fluctuant jaundice?
Sir, intermittent jaundice is seen in choledocholithiasis, sir. When stone is passed out, that jaundice will come to lower
Not
limit.
necessarily, 1 minute, not necessarily stone is passed out.
Yes,
even when the stone is in the CBD,
yes,
the jaundice levels can come back to complete normal. Okay.
Yes, sir.
Can you
That
hear
is
me?
intermittent jaundice,
Yes.
sir. And fluctuating jaundice is seen in ampullary carcinoma, sir. That tumor necrosis will sloughed off. That will cause decrease the bilirubin level, but it's not come to base level.
So it will never come to the base level.
Base level.
And your presentation is fine. There are some questions related to somebody has asked, so I'll also ask that same. What is the importance of blood transfusion in this case?
Yes, sir. Blood transfusions will cause hepatitis, sir. That will also cause
You
jaundice.
wanted basically recent history. Okay, recent history. That's what you are trying to tell.
Yes, sir.
Is that the one? Yes. Yeah, that's all from my side.
Thank you, sir. Thank you.
I think we'll go to the
We'll proceed with the
examination.
examination.
Examination findings. Yes, sir.
General physical examination. Patient was examined in a well-lit room in broad glare light after taking informed consent with adequate exposure from neck to mid-thigh. Patient is conscious, coherent, and oriented to time, place, and person. Moderately built and nourished. Height is 160 centimeters and weight is 42 kgs. BMI is 15.5. He is underweight. Pallor could not be assessed. Icterus is present. No signs of clubbing, cyanosis, edema, and generalized lymphadenopathy. No signs of liver cell failure. Multiple scratch marks all over the body noted. Performance score is ECOG 2. These are the scratch marks are present over the back. Vitals, pulse rate 68 beats per minute in right radial artery, which is regular, normal in volume and character. Blood pressure is 90 by 60 millimeters of mercury in right hand supine position. Respiratory rate is 60 cycles per minute. Saturation is 99% at room air. Temperature is 98.6 Fahrenheit. Examination of abdomen. Inspection. Abdomen is flat. Umbilicus is centrally and inverted. No localized fullness seen. All quadrants are moving equally with respiration. Yellowish discoloration of abdomen with multiple scratch marks are noted. No visible pulsations or peristalsis noted. No scars, sinuses, and engorged veins over the abdomen. External genitalia appears to be normal. Hernial arteries and spine appears to be normal. Palpation. All inspectory findings are confirmed by palpation. No local rise of temperature. Abdomen is soft and non-tender. Gallbladder is palpable up to 4 centimeters below the right subcostal margin. No organomegaly. Hernial arteries are intact. External genitalia normal. Percussion. Liver dullness extending from the 5th intercostal space to 2 centimeters below the right subcostal region. Liver span is 12 centimeters. No shifting dullness. Auscultation. Normal bowel sounds are heard. For rectal examination, sphincter toe normal. Clay colored stools are present. No deposits. Other systemic examination, respiratory system. Normal vesicular breath sounds are heard. No added sounds. CNS patient is conscious, coherent, and oriented with time, place, and person. No focal neurological deficits. Cardiovascular system, S1, S2 are heard. No added murmurs. Provisional diagnosis: 64 years old gentleman, non-diabetic, presented with complaints of yellowish discoloration of eyes, itching all over the body, dull aching pain abdomen, associated with passes of eye-colored urine, clay-colored stools, with on and off fever, significant weight loss with decreased appetite. On examination, he was thin-built, purely nourished, and underweight. He was icteric. Abdominal examination revealed a palpable gallbladder. My provisional diagnosis: obstructive jaundice due to malignant etiology. It's most probably a carcinoma of head of pancreas. Second, mostly ampullary carcinoma. Third is distal cholangiocarcinoma. Fourth one is carcinoma, duodenum, second part of duodenum.
Go back to your examination findings, Rajashekhar. I think sirs have some questions for that. Your palpation of your liver. So here you've said gallbladder is palpable 4 centimeters below the right costal margin. So how are you saying it's the gallbladder?
It's globular in shape and it is moving along with the respiration, madam. It is superior part is not palpable and medial lateral part and inferior border of the mass is palpable. And it is not unable to move along in the.
Is this okay?
Where is it present? Which part of the subcortical margin is it present?
Right.
Which point? Tip of the 9th subcostal cartilage, isn't it? In that region, mid-clavicular line. So, I mean, generally in this, we begin with whether liver is palpable or not. Was the liver palpable?
No, sir. No, liver is not palpable.
In one slide, you have written 2 centimeters below the subcostal margin, no?
That is percussion, sir.
On percussion, you felt. Okay. Liver dullness extends about 2 centimeters
below the right subcostal.
And gallbladder, is it dull to percuss or no?
It's dull to percuss.
Dull to percuss. What is the normal kind of mobility the gallbladder exhibits?
It will mobile in horizontal direction, sir.
Mobile also in horizontal direction. but prima facie it moves along with the respiration. So these are the findings that you need to place. So there is a mass, there is a lump or mass felt in the
Right
subcostal, right, which moves with the respiration and exhibits horizontal mobility. So firm inconsistency, isn't it? And dull to puff. So it looks more likely to be a gallbladder mass in view of obstructive
Jaundice,
isn't it? That's how you have to put. And also liver span is increased up to 2 centimeters below the subcostal margin, isn't it? That's what you want to put it as.
Yes, sir.
Yeah. And very significant finding is a perrectal finding of
Only clay colored stools are present,
no,
sir.
no,
And
that is a very significant finding is clay colored stool.
clay colored
Okay.
stools.
Yeah. Very significant finding will be a clay colored stool or pale colored stool. Means you will not have any, the kind of color will be pale colored stool. So it's very most important finding in an obstructive jaundice. That is what you will make out clarified. And sir was asking, are the scratch marks even on the back or only in the front?
Everywhere is there, sir, significantly on back
Everywhere.
side.
Also on the back. Okay. And did you make out jaundice on the palm?
Yes,
In
sir. Yellow
the
discoloration of palms and soles also there. It is extending till the palms.
so it means it's quite deep jaundice, isn't it? Quite
Yes,
a
sir.
deep jaundice. Okay. And he's lost a lot of weight, cachectic.
Yes, sir.
And gallbladder is palpable. So
Yes,
you are coming to a conclusion of these findings, isn't it?
Yes, sir.
Sir, anything to be added, sir? Rajagopal, sir?
One or two things,
Madam?
Rajashekhar.
Sir.
See, what happens in the exam is that we would like to know that whether the postgraduates have properly examined and got the findings. In that way, we think. So it's not about that you knowing the diagnosis. Many of you will know especially now you know it's ultrasound finding, CT finding, everything. So just go back to the slide in which you straight away wrote as gallbladder is palpable. Just show me that slide. Yeah, just hold on. Yeah, that's all. So my question to you is that why not it's carcinoma gallbladder? Suppose I will ask that question to you. So in other words, you should not get biased with the one finding what they have written and he has come to you and show you the finding. So consistency, did you mention about it? So, and your whole case in your exam, MS exam, it's a obstructive jaundice patient and one gallbladder palpable.
Yes,
so other way of putting it is that you can nicely say that there's a mass palpable, whatever you have mentioned, right? Subcostal margin or right hypochondrium, or where exactly you can say, right, lateral to the rectus abdominis muscle or whatever it is. That's where I was talking in the last clinics about the shape. You know, you have mentioned that at the end, you know the gallbladder finding. So you can always tell it's a typically egg-shaped mass. Classically, what I'm talking, the classical one. So Dr. Savita has asked a question. Why not you differentiate from the caudate lobe of the liver? Correct, Dr. Savita? Did you ask that question? Doctor, how to differentiate palpable gallbladder and caudate lobe hypertrophy?
She has asked the question, yes.
Yes, sir. In consistency, it is cystic in consistency, cystic to firm in consistency in gallbladder, sir.
Again, same thing. What I'm trying to tell, intra-abdominal cystic swellings. Don't try to tell, cystic, fluctuant and all that thing. Okay. It will be difficult to get tensely cystic swelling, that too inside the abdomen, that too with the abdominal wall muscles. They feel firm only. You understand, no? The mobility, you may be able to move it. So, and location, consistency, movement with slight mobility and a little inferior to the inferior part of the liver. That's how you differentiate. The whole idea of we asking is don't write it as gallbladder, straight away say mass is palpable.
Okay.
That is okay. Consistency are not mentioned here. So that these are the few comments from my side. Dr. Sunil, there are some questions in chat box. Can you see that?
Yes, sir.
And just see.
So it is more or less multiple questions about this gallbladder and caudate lobe. And Dr. Sandeep said he can't say it's gallbladder enlarged, which you already spoke about. So I think more or less all the questions are answered, sir. We have, yes, sir. All the questions are answered. We can
Why
proceed.
I asked about scratch marks on the back, Dr. Rajashekhar? Why did I ask that? Where is the common area where everybody scratches? I'm not trying to.
Yes, sir. Limbs are the most common areas, sir.
In other words,
Accessible
whichever
to-
is the easily accessible areas, you know what happens specially. So
Yes, sir. Limbs
trunks,
are-
legs, etc. Back, you know, to okay.
Someone else is scratching. Sorry, on a lighter note.
Yeah, he must have made someone scratch his back. So, can we progress, sir? Can we go on for the investigation or manage?
No, plane of the swelling is asked by Dr. Nandish. He wants to know what is the plane of the swelling or
It
the
is intra-abdominal, sir.
Okay.
Intra-abdominal, intraperitoneal. Okay, that's how it goes.
See,
Right.
that's
It
what
moves-
he has written as gallbladder palpable. So it is taken for granted that it is intra-abdominal, intraperitoneal. Otherwise, they would not have asked that question. So see, okay, yes.
Continue, Rajashekhar.
We'll proceed next then. Next, please.
So your provisional diagnosis is periampullary. Okay.
Periampullary. Most common is carcinoma bed of the pancreas.
Okay.
Okay.
Investigations.
Biochemical investigations, complete blood picture, WBC counts are 15,000 and HB is hemoglobin is 8.7 milligram per deciliter. Liver function test, it shows total bilirubin is 18 milligram per deciliter. And ALP is significantly raised. And serum albumin is also 2.0 gram per deciliter. And tumor markers CA 19/19 is 732 units per milliliters. And USG abdomen, it shows intrahepatic biliary radical dilatation present. And gallbladder is distended with normal wall thickness. CBD dilated, measuring 15 mm at porta, and distal CBD obscure. No free fluid. CCT abdomen and pelvis suggestive of bilateral IHBR dilatation. Left is more than right, with dilated CBD measuring 16 mm at mid segment and dilated tortuocystic duct secondary to obstructive heterogeneously enhancing mass lesion in the head of the pancreas. It measures 2.1 into 2.6 centimeters in anteroposterior and transversely. Pancreatic duct dilated, measuring 2.7 mm. Gallbladder grossly distended, appears unremarked.
No, before going to that, can you what about the portal vein? And they have not mentioned in this one, is it? In the CT scan, portal vein and lymph nodes. I'm not able to.
They're not mentioned.
Mass in the head of pancreas. So what are the important things that you will see?
Again, as sir
once
said,
you have-
metastatic workup or extension.
Yes, sir. Metastatic workup. We did this chest X-ray, sir, in that there is no metastasis in the chest.
Regional spread and the
Distant metastasis, sir. Regional metastasis we rule out with the CCT abdomen and pelvis. There is no involvement of portal vein or superior mesenteric artery or celiac axis, sir.
So these are all signs of
Distant loco-regional metastasis, madam, and there is no lymphadenopathy.
So why do you get the CT done? What else do you want to see in this? Whether the patient can be
operable or inoperable.
Mesenteric vessels.
Signs of operability.
Yes, signs of operability. There is no involvement of superior mesenteric artery, and they maintain the fat planes, madam, in between the tumor and the vessels. And there is a fat planes in between this portal vein and this splenic vein also. There is no distance metastasis in liver, and there is no ascites in the abdomen. It's
So there is a little bit of little bit of fallacy. He's got quite a deep jaundice, and there is no this will be in a critical point, I think, at the junction. So he's come a little bit early. Otherwise, generally it would already be late with the kind of history, cachectic person. So it is unlikely to be that it is not really spread. It will always be spread. So here you've got a tumor, and they've not mentioned that there is no lymph nodes, isn't it? I think
Yes.
it should be very clearly reread and recheck whether there is T, N, and M. So T is only thing that is really mentioned. N they have not mentioned, and also in relation with the vessels, because once you go in, you cannot come back. It's quite a difficult thing. So counseling, everything occurs most likely pre-operatively, isn't it?
Yes, sir.
Yeah. So what are the signs of inoperability in a CA head of pancreas?
Yes, sir. This local regional metastasis like ascites any is there, or distant
Right.
metastasis to lungs,
No, local
liver.
first, regional, and metastatic. Local, what are the factors
Local,
for
sir,
non-operability?
the tumor it get
Inoperability.
surrounded around the mesenteric at 180 degrees, more than 180 degrees.
Okay.
And there is also around the superior mesenteric portal vein and splenic vein.
Yes.
Abstinence will be there, and there is no reconstructable, sir.
Okay.
This is the local regional, and distance metastasis is there. There is no inoperable.
Celiac axis lymph nodes, isn't it? They become inoperable. Okay. Ascites, liver mets, right?
Yes, sir.
And at times with the CT, you can make out peritoneal mets. At times, if it's very large, you can make out peritoneal metastasis. Other thing which you can make out on CT is lower lung zone metastasis, because you would have taken cuts for lower lung. So with the CT, you can pretty much get a good idea of the status of the thing. And the rest of the pancreas, how it is, whether there is any evidence of pancreatitis.
Yes.
That has to be mentioned. Okay, fine. Then metastatic workup, how would you do? What are the metastatic workup you would plan for?
Sir, metastatic workup initially we did chest X-ray, sir. In that
Okay.
there is no lesions are seen. Then we go with CCT abdomen and pelvis along with HRCT, sir, to rule out any metastasis.
Excellent. Okay. Now that it is supposedly localized to the pancreatic head with no lymph nodes, no lymph nodes and no distant metastasis. That's what you would like to put it as, huh?
Yes, sir.
Yeah. So now what is your plan of care
So
and
there's a
what would
question,
you?
sorry to interrupt. Role of
Yeah.
upper GI endoscopy in workup by Dr. Savita.
Yes, sir. Role of upper GI endoscopy. Upper
How will
GI
it help? What will help?
endoscopic ultrasound we can do, sir, for periampullary carcinomas. Like ampullary carcinomas, patient is not inoperable. We are going with neoadjuvant chemotherapy. That time we can do FNAC or biopsy from the ampullary region, or breast cytology we can do. Based on that, we can go with neoadjuvant therapy, sir.
Okay.
This neoadjuvant therapy will really help in this condition. I mean, it's an operable case. Neoadjuvant will not be. What is the idea of endoscopy? When do you do endoscopy in obstructive jaundice?
Yes, sir. Any esophageal viruses or any GI
No,
malignancies.
not that.
Anything,
No.
can
The
you
idea
relieve
will
the
be
jaundice?
Yes, but CS stomach will cause.
No, Rajashekhar, you're not understanding sir's question. Anything else you'll do with endoscopy for this patient? You can do
intervention.
Intervention.
Yes, madam. ERCP we can do.
So generally, we reserve ERCP for if there is cholangitis, symptoms of cholangitis. Otherwise, if it is obstructive jaundice without features of cholangitis, we would prefer it to be planned for surgery. So role of endoscopy will come in cases of periampullary carcinoma. So wherein you need to get a biopsy, if it is growing into the ampulla of weight. Okay, that will be the
Tejaswini ma'am
main
is
role.
asking. Sorry, sir. Continue.
Yeah, please.
Yes, sir. Tejaswini ma'am is asking any role of drainage in this patient.
As of now, patient is not in cholangitis and the patient is pruritus is also not that much.
Okay.
Maybe we'll directly go with surgery.
Directly go with surgery. What are the indicators that you can? I mean, surgery is a major thing. Okay, so before surgery, what is the factors you would like to correct the patient for?
If patient is any anemic, we can correct the anemia and nutritional status also to correct, sir.
Nutritional status has to be corrected because what are the important things nutritionally?
Albumin level, sir.
Albumin level. Second important thing. Coagulation factor, no?
Coagulation
So
factor,
they'll be deprived of the coagulation. So you have to correct. Yeah, correct all the thing, and then only you can take up because it's a major surgery and with a great perioperative mortality. So it's very essential to know the status. So what surgery would you prefer?
Sir, Whipple's pancreaticoduodenectomy.
Whipple's pancreaticoduodenectomy.
Followed by pancreaticojejunostomy, hepaticojejunostomy, and gastrojejunostomy.
So which are the three anastomosis?
Pancreaticojejunostomy, sir, followed by hepaticojejunostomy or choledojejunostomy, followed by gastrojejunostomy.
So of the three, which is the most important? First, which is done?
Pancreaticojejunostomy, sir.
And the most dangerous, isn't it? Most dangerous.
Yes, sir.
Sir, madam, any questions you want?
Okay, anything you've done any surgery on this patient, Dr. Rajashekhar?
Yes, madam. We did pancreaticojejunostomy. Whipple's procedure we did, madam. Pancreaticoduodenectomy.
Do you have any pictures or anything that you have put in the presentation?
No, madam. Not.
Okay. So, pretty straightforward thing. Do you want to quote the Cavoisier's law again? I mean, are you aware of the law?
Cavoisier's law, madam. Yes, madam. Gallbladder is palpable. In obstructive jaundice, gallbladder is palpable, seldom due to gallstones.
In obstructive jaundice, if the gallbladder is palpable, it is seldom due to
gallstones.
Okay, that's how it is.
There is couple of questions there from the audience.
Yes, sir.
So, role of FNAC in pancreatic head mass.
Yes, sir. Usually, if patient is the tumor is operable, we are not going with the FNAC, sir. For any neoadjuvant therapy, that time we will do with the FNAC of head pancreas.
You have done a tumor marker, no? Tumor
Yes,
marker is elevated. Which tumor marker you have done?
CA 19/9, sir.
19/9, which is very elevated, isn't it?
Yes, sir.
Other thing is endoscopic biopsy, if it is possible. Only there you will do a endoscopy. Generally, FNAC is done if you have a doubt between benign and malignant cause. Chronic pancreatitis of the head versus malignant mass. Okay. Otherwise, FNAC is reserved for the mass. Another thing, sir has pointed out, if there is lymph nodes around the pancreatic head, which you would like to confirm, then you can do a EOS guided FNAC of the lymph node. Okay. But in general, if it is pancreatic head mass with lymph nodes, you would assume it to be malignant malignant. So you'll need to do lymphadenectomy. All right.
Rajashekhar, good presentation. Sapna, can I speak? Nice to listen to you.
Hi, ma'am. Yeah, definitely, ma'am.
Any role of IORT here? Rajashekhar? Intraoperative radiator pain?
No, madam, no peritoneal metastasis is there. No peritoneal
Okay.
metastasis.
Different options for palliation. It's good that you are able to do a clearance surgery here, but normally most of the time it's not possible, isn't it? So what are the palliative options in such patients?
Yes, madam, to relieve the obstruction of the bile, madam. For that, we did here we can do ERCP and CBD stunting.
Okay, normally what should be the limit of bilirubin, serum bilirubin when we suggest that they can go in for a drainage ERCP?
20 milligram per deciliter.
Yeah, okay, right. Any other options?
If obstructive jaundice is lower and distal CBD obstruction, we can go with ERCP, madam. Proximal, we can go with PTBD, madam.
Right. Prognosis?
Prognosis we measured with CA 1919.
So where does this fellow stand?
Poor prognosis.
Yeah. So how many months or period you expect him to survive? Because this is one of the important things we tend to miss in discussion. At the end, what are we going to talk to the patient and the attenders? Right?
Yes, ma'am. 6 months to 1 year.
Okay. And what you expect him to, if with whatever interventions we are doing, how much you expect his quality of survival to improve, and what should be our goals here as a treating surgeon?
Life expectancy will increase, madam.
To some extent, agreed. So
And
please remember,
morbidity also we
especially
can
when we
decrease.
talk of these terminal malignancies, and majority of the time our intervention is not curative. We have to have a clear understanding of what we expect at the end of the treatment there. At least his quality of life should improve. At
Quality
least
of life should
while
improve, madam, and jaundice will decrease.
decrease.
It will cause the pruritus also will come down.
Yes.
And lifestyle modification will happen.
Okay, right. Nice. Good presentation. Thank you, Sapna and team, for
Okay,
allowing
thank you.
us.
Thank you
madam.
so much,
Thank
ma'am.
you.
It's a pleasure to
Thank you,
see
Tejaswini
hear
madam.
you again.
Thank
And,
you, sir.
And actually, there is a good comment by Dr. Nandish, who is a senior teacher, that
Yes, sir.
reasonable diagnosis based on clinical analysis is required more
Yes.
than correct diagnosis when presenting a case in exam. I think wonderful words there. I think that's what PG Clinics is here for.
Definitely.
Sir, any?
Firstly, let me thank Dr. Tejaswini madam for joining and your suggestions for this. One or two things for our postgraduate that see, one thing I think because of the online we might have missed. You are in your patient total count is elevated, correct? You just escaped that. Show that blood test CBP 15,000, correct?
Yes, sir.
Rajashekhar, yes, show.
WBC comes to 15,000.
So do you think it's normal?
No, sir. He's in cholangitis, probably suspecting cholangitis.
Did you ever mention that if there's a patient who has got cholangitis, remember the danger? Just because 15,000 does not mean you can ignore it. So more than bilirubin levels, bilirubin 18, 20, 22, 23, 24 is okay. There is a cutoff, some controversial issue, but counts are important. Okay, so count can be due to many other reasons, but this is what you should understand. Okay, right? Yes. Secondly, the diagnostic use of an endoscope in your patient is side waving scope. You should always mention endoscopy by side waving. Okay, to see the second part of the duodenum and take the multiple biopsies in case if you suspect ampullary or periampullary carcinoma. Okay.
Yes, sir.
Diagnostic. Never mentioned ERCP.
Okay, sir.
Never mention ERCP. What is the danger of ERCP?
It will causes perforation of duodenum. Or
what is the danger of ERCP?
Itself it causes cholangitis, sir.
See, it's an already obstructed system. Why you want to introduce infection? Unless you want to make it a Make it a drainage. Drainage. For some reason, you want to put a stent in patient who has got cholangitis, severe itching, intractable itching. You will not get the date or time. Whipples is not a small surgery. It takes some hours. So sometimes you will give the patient 2 weeks, 3 weeks later. Sometimes nutritionally they may be very bad. So poor, low albumin, nutritionally poor patients, where you want to buy some time, then you want to drain, then yes, ERCP. Otherwise, a patient where it is operable, so it straight away will go for a pancreatic duodenectomy. Last question from my side.
Yes, sir.
Did you understand the logic behind not doing FNAC of the pancreatic head mass?
Yes, sir.
What is the logic?
No, if tumor is
Sorry?
resectable, there is no need for FNAC, sir.
No. Why? Reason is simple. Number one, it is deep-seated pancreatitis, bleeding, and last but not the least, tropical, especially our areas, Kerala pancreatitis, chronic pancreatitis, presents as a head mass. So you should not think it is benign, because for pathologists also, FNAC is extremely difficult to differentiate chronic pancreatitis, which is benign, from malignancy. Is it clear?
Yes, sir.
So that is the main reason. On the other hand, if there's a peri-pancreatic head region, there are nodes. Endosono-guided FNAC can yield a better result rather than a FNAC of the pancreatic mass. In spite of all these things, technology is advanced. They may do it, but that's a different issue. At your level, it's better to say no. These are few things from my side. I think just we can stop, I suppose, or any other comments from anyone else?
I think it's a good presentation, sir. And congratulations to both the presenters for making a wonderful presentation. And I think this platform is quite nice to have across people to come over and having quite very great teachers like Shunais or Naz Madam at one platform, which I think is very difficult otherwise. So I really congratulate the society to give an opportunity for the students and for us to be interacting with different students at one given point of time, and also with our own colleagues who can give us the thought processes at one go. Thank you, sir. Thank you, Sunil Joshi, sir. And thank you,
Sunil
Rajagopal.
Joshi, sir.
Thank you.
Like sir said, it's an amazing platform where all the stalwarts of surgery are also there. All the stalwarts are also there. I have Tejaswini ma'am, who's my teacher also in the same thing. Thank you so much for this experience, as well as both the PGs presented very well. Thank you so much. That's it, sir. Thank you.
Thanks to the PG presenters and the examiners as well.
Yeah.
I request
Dr. Sarvesh,
sir.
Yeah. Yes, sir. Today is liver day, actually. We successfully
Hepatobiliary masterclass.
Yeah.
Kingfisher Day.
Yes.
Yeah, very nice.
Successfully completed the third PG session under the leadership of our chairman, Dr. K. Rajagopal. I congratulate the PGs, the examiners, and the moderator for today's PG presentation. And I request Dr. Gurban Basangoda to present the vote of thanks. Sir, please. Guru Basangoda.
Yes, sir. Yes, sir. Good evening, everybody.
Yes.
Thanks for the opportunity to give me a vote of thanks. And first and foremost, I congratulate everybody for having successful meet here. And foremost of this is for our really enthusiastic chairman, Professor Rajagopal, sir, Secretary Sarvesh Rajaras, and academic committee members. Of course, the two examiners here, Dr. Sreekar Pai, Dr. Sapna, Purushottam, madam.
Thank you,
We
sir.
wholeheartedly thank you for being the examiners for this KSCASI event. Sunil, Joshi, my friend, thanks a lot for your wonderful, enthusiastic moderation. I keep seeing your messages, and it started today in the morning around 5:30, I think. And you are very well going through all the messages and coming in between the presentation and to make your point of making your points of others by meditating by yourself. Thank you, Dr. Joshi. Sreekar Pai, sir, thanks a lot.
Thank you, sir.
For having
Thank
this.
you, sir.
Of course, again, other participants, Naz ma'am, President-elect, Chairman-elect, for always interactive in any sessions. Thanks, ma'am, for making it done to this event. And of course, Dr. Tejashwani, madam, who is our guide here. Thanks, ma'am, for joining this and giving your great inputs here. Of course, presenters, residents, Dr. Vivek, Dr. Rajashekhar, without whom who made a good presentation in this PG student session. I thank again EC members, state as well as national, sir, or my teacher, Dr. Purushottam sir, again here. All the participants, admins, again, thanks one and all for making your time for this event and having a great success. Thank you all.
Yeah, thank you all. Good night.